Okay. Um, so this little slide deck was made by Notebook LM. I don't really know what that first picture was trying to be, but it doesn't look great. But they are just saying that there's 500,000 plus annual burns, 3,000 annual deaths that include smoke inhalation, which is so scary. I mean, especially with, I know obviously we're talking about snow, but there's a huge issue when it comes to fire and smoke inhalation with carbon monoxide poisoning. And I'm sure with all the snow that we've gotten, we've all thought about making sure our furnaces weren't putting out carbon monoxide, and hopefully every one of you have a carbon monoxide detector in your house. And, you know, there are over 400 people, I believe, a year that die just from carbon monoxide poisoning. So that's a small part of smoke inhalation, just because that's the byproduct, part of the byproduct that is like burned off. And when you have like a gas fireplace or a gas stove, or I have a gas dryer, and your house isn't ventilated properly, if your furnace is old and it's trying to work really hard, you know, especially with, and I'm just like relating it to what we're going through right now, it can be really dangerous, and is also a part of the smoke inhalation deaths. So the health department has posted that we should clear the snow from our vents. Yes, I sent my husband out yesterday. Actually, I was on TikTok. I love TikTok. I know how that sounds, but, and first of all, we all do, okay? But I saw a TikTok about some guy talking about making sure that you go outside and make sure all of your exhaust pipes, like from your house, from your gas, from your dryer, from your blah, 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 is all clear. So Christopher went out last night and made sure that everything was uncovered and safe. So the most vulnerable populations are always going to include the elderly and children. I mean, obviously everyone is at risk for burns, but older people and small children have a hard time regulating their temperature, which you're going to find out is a huge issue when it comes to burns. Smokers, because there's open flames usually. Now, I don't remember when it was. It was when I was a smoker, which is when this happened, which was, God, at least, I don't know, I feel like this was 20 years ago. Am I that old? Oh, Jesus. Anyways, when cigarettes, when they added like the flame retardant to cigarettes so that they would stop catching people's couches on fire, because that was actually a huge risk for cigarette smokers before that, because they would fall asleep and drop their cigarette on the couch, and then the couch would light on fire. And it happened way too often. And then comorbidities, of course, diabetes, neurological illnesses, people that are immobile, can't get out of wherever they need to be, don't have the understanding of how burns can affect you, and, so most commonly we know these three different types of burns, right? So we have our first degree burn, which is superficial. I can guarantee that every single one of us has experienced a superficial first degree burn. This is where only the top layer of your skin is pink. It can be dry. It can be painful. It's blanchable. So remember, blanching, if you don't know what that means, it means that when you press your finger into an area of the skin and you lift it off, it's normal that that area of skin turns white because you're stopping the blood flow to that area. What is abnormal is if when you take your finger away, it doesn't automatically turn back red or a color. You know what I mean? So when we say that something is non-blanchable, like a pressure wound, that means that the skin does not have good vascularity. So those little capillary beds right at that level in the epidermis are not getting enough blood flow. So if you didn't know what blanching and non-blanchable skin meant, now you do. Okay. Somebody needs to put their thing on mute. Unless you have a question, then please ask questions. So then we have our second degree burn. So under the first degree, it does say sunburn. Sunburn can go from first degree all the way to third degree, depending on, the level of sunburn. Normally, your sunburn is going to be between first and second degree. Okay. So with second degree, this is partial thickness, epidermis and the dermis. It is red, it is blistered, it is weeping. At some point, I can bet that every single one of us, especially we're all women, we've all used an oven, at least you've been outside in the sun. I feel like if you've gotten this far in life and you've never had a sunburn that blistered, you're very lucky. But they are very, very painful. So when that blistering occurs, the pain is because the burn has reached your nerves. Okay. Yes, your superficial burns are painful, but they are nothing compared to the second degree. Okay. Full thickness is, I think, God, that I've never experienced a third degree full thickness burn. If I have, it was last year, or I think it was about last year. I got burned when I was cooking a steak. I think I told this story. And I was like putting the butter on top of the steak, and my pan got too hot, and the butter bubble popped. And it hit my arm, and it was, oh my God, it was excruciating, because oil just continues to burn. And we're going to talk about the different types of things that burn on the next slide. So these are the ones that the third degree can be very painful or no pain. So this says it goes through the hypodermis. You have eschar, which is leathery/charred skin. If you have complete nerve destruction, there is no pain. Okay? Because, and I'm not talking about no pain, because if you've ever seen a person significantly burned, you know that they're in an excruciating amount of pain. But it's not from the burn itself. And we're going to talk about that too. When the nerves are completely burned through, that nerve pain is not there. And then you require grafting, which we're also going to talk about. So there's multiple different types of burns. So thermal is going to be heat, steam, fire, and this is your most common, right? This is your oven burn. This is your, which a lot of people get confused when they talk about sunburn. They think sunburn is thermal. It's not. It's actually radiation from the sun rays. So make sure you don't confuse that. So thermal is going to be your most common. And then we have a chemical burn, which can happen with acids. And I don't know if it can actually happen with both alkaline and acid, but it makes more sense that it's saying that the acid is causing the burn and the alkaline is what we use to neutralize it. So if you've ever, every place that you have a job has what's called an MDS, Material Safety Data Sheet, MSDS, there you go. Whew. An MSDS, like binder or, something of that sort. It's required by OSHA to have, it's for every company to have one of these. And the point of it is that it lists every single chemical that you have inside that facility and what to do about it. So there are things that you can get a chemical burn from that you should never put water on. Okay. And we're not going to go through what exactly those things are. I do not expect you to know that. What I do expect you to know is where to find this information, which is in your Material Safety Data Sheets, MSDS, which is required by OSHA. So after you neutralize the acid is when you should irrigate the situation. And a chemical burn really should always be evaluated by a physician because you don't know the extent of the damage from the chemical right away. Chemicals, radiation, oils, these can continue causing damage well after the actual burn occurs. Electrical. So electrical is scary because it causes internal damage. We've talked about defibrillation a lot. My students at clinical this past Thursday, we had the opportunity to, I literally put myself on their defibrillator, and I was showing them what it looks like to sync to someone's heart rate. If you haven't had that opportunity, hopefully in lab we can talk about that when I see you guys this week. But the iceberg effect is like you run into an iceberg, but like it splinters throughout the whole thing, right? It's not just like you burn on the outside, it goes throughout your body. And obviously, our heart is maintained by an electrical rhythm, right? So if you get electrocuted, it can cause your heart to go into an arrhythmia. Okay. Radiation, I feel like, is a little self-explanatory. This is your sunburn. This is your radiation treatment for cancer. Excessive imaging like MRI, CTs, X-rays. People that work in these situations, they have to wear radiation badges, and they get changed every year. And the point of it is, I believe, OSHA regulates that. And those badges help to determine how much radiation exposure you've had throughout that year. And then they get replaced, they should be getting replaced yearly. Frostbite specifically, if you did not know, you should always rewarm a body part that has been exposed to frostbite very, very slowly. So if you have hands that are the temperature of, I mean, our normal body temperature is 98.6, right? It's what, 6 degrees out, 14 degrees outside right now. Frostbite is going to be a huge issue for probably our homeless population right this minute if they don't have a shelter during these times, which is really sad to think about. But the frostbite has caused the vascularity to, basically freeze. Like, think about pipes. Your veins, your capillaries are your pipes, right? And if your pipes get frozen above the injury, then there's no blood flow that's occurring to those fingers, right? I'm using fingers because I can see they're showing hands on here. So you want to either put your hand in water that is only like not even lukewarm, because think about how cold your hands would be if you immediately dunk your hands into hot water. First of all, it would be extremely painful, and it would make the frostbite worse. So you would want to start with either cool water or very, very room temperature water. And then as the skin starts to warm, you can warm the water as your hands or extremity or whatever warms, but never use hot water immediately. Friction. If you've ever played tug of war, this is your classic rope burn. Road rash, if you're, on a motorcycle, you get in a car accident, anything like that. You're on a bike and you wreck your bike, bicycle. And so this is just the mechanical removal of skin. So it's literally like being sheared off of your body. And it's painful. So the systemic complications, and this is the biggest part when it comes to management for your patients. Okay. So Number one, smoke inhalation. I know I talk about Grey's Anatomy all the time, but it's just so valid, okay? If you haven't seen in the, what is it, the first season, second season? I don't know. Oh, it has to be the second season or third. April Kepner, she gets fired because they had burn patients come in. It was a mother, I believe, and they were rushing through her assessment, and no one looked at the patient's airway. They never looked in the back of her mouth. And the reason that that's important is because you can have like soot marks, like black marks in the back of your throat and like mucosal redness, any swelling, like you can see that there's an injury to the airway from smoke inhalation. And she was fired because that patient ended up dying from a inhalation injury, and nobody had looked at her airway, and they ended up finding out that it was her patient, and she's the one that did not do that. So smoke inhalation can be just as, if not more, to be honest, if not more, deadly than the actual burn itself. Okay. So and it's not only just about carbon monoxide, because that is a small piece when it comes to smoke inhalation. It's about the heat from the smoke and the destruction and irritation that it's causing when it's going into your lungs, which is causing, oh, something just dinged, the airway and the lining of the lungs to swell to the point where you can't breathe. Sarah said it's season 6, episode 6. Yes, absolutely. So we very briefly touched on fluid and electrolytes when we were talking about hypovolemia. This is extremely important when it comes to third-degree burns, okay? Put a star. I want you to put a star on this slide right here. So what happens is, and we were talking about hypovolemia, and we were talking about that if you think about your cell like a water balloon, we've learned over the last couple months, if you didn't learn it from somewhere else, you definitely learned it from me, that potassium is intracellular and extracellular. We call it a intracellular ion because most of the potassium lives within the cell, okay? The extracellular potassium is what's in the serum. That's what we're testing every time we get a BMP or CMP. We're testing the serum, the extracellular potassium. So if our cells are water balloons, and they get destructed, which is called cell lysis, lysis meaning destruction, and that water balloon breaks, busts open, then all of that intracellular potassium is going out of the body, okay? Now, this can cause both hyperkalemia or hypokalemia. And you say, Jess, how is that possible? Well, if you have an extremely large third-degree burn and all of your water balloons in that area have popped and have leaked out of the body, right? It's leaking out of the body. Then all of that potassium is leaking out of the body. You can't have hyperkalemia if you're losing all the fluid, okay? If the third-degree burn it's large, but it's not, gigantic, you can have that fluid shift with potassium ions, and the cell lysis, it causes those water balloons to break, but that serum, you still have circulation happening, so it bleeds into the circulation throughout the rest of your body, causing hyperkalemia, okay? Do you see the difference? Also, when we're losing a huge amount of volume, whether it's blood, fluid, whatever, we have a risk of going into hypovolemic shock, which we talked about last week. The last part is called compartment syndrome, which we have talked about. I know we've talked about it. And this is when, now usually compartment syndrome happens inside of a cast. When I told you guys about the little kid that got his legs stuck in the bed frame, and who knows how many hours it had been, and when his dad went to go get him, I think he was like 4 years old, his legs were stuck between the slits or slots or whatever in the bed, and he ended up having compartment syndrome of both legs, and we had to do what's called a fasciotomy to relieve the pressure. Okay, the compartment syndrome for burns, it's the same thing, but it's actually caused by that eschar material that's left behind, and it's hard. It like hardens, and then it acts like a tourniquet. So the swelling that's happening within that area of the body, it has nowhere to go. And that's when it can require a fasciotomy. Fasciotomies, whatever the cause is, can be very dangerous, especially if it's on the chest, if it's in the abdomen. Thoracic compartment syndrome is extremely life-threatening because it can actually stop you from breathing. Abdominal compartment syndrome is also a terrible situation, not as bad as thoracic, because if you can't breathe, you're going to die. So thoracic compartment syndrome is going to be like the scariest, and the neck. If you have third degree burns to the neck, and you have eschar on a lot of your neck, it can cause compartment syndrome. Obviously, if you have compartment syndrome of your neck, that's where your airway is. You're not going to be able to breathe. Okay. So, we have 3 phases of burns. The first emergent phase is within 48 hours. One of the biggest things during this phase, is the biggest thing during this phase, other than airway, is resuscitation, fluid resuscitation. Fluid resuscitation for burns is like any other resuscitation you will ever see. Okay. So the focus is on fluid resuscitation and shock prevention. And your key action is going to be, of course, your airway, and then your fluids so that your cardiovascular system does not collapse. And then we talked about just a tad, and I've told you we're going to go back to this, is thermoregulation. Your skin, and we've all heard this, is your biggest organ, right? Your skin is what aids you. Not only does your brain and your thermoregulation in your brain have to work, but your skin has to be intact to keep the warmth in, okay? The skin is your walls of your house. It needs to be insulated, right? It's your insulation, it's your walls. So if you're taking away a wall from your house, you can't keep the heat in, okay? So then the acute phase is 48 to 72 hours, or to however long it takes that wound to close, or however long it takes surgery to close that wound. Because sometimes, if the burn is extensive enough, we have to put some type of closure on there to help with the healing process and also help with that thermoregulation. The focus is on wound management and healing, and infection prevention. It is so easy to have like terrible infections when you have really big burns, especially if they are in places that are easily soiled. So for this, you may have to look at diuresis because of all of the fluid and swelling accumulation. The diuresis, this is not in every person situation. This is if you need it then you need it situation. Infection control for everyone. Nutrition, we've talked about how important it is for protein and amino acids. So it's very important that these patients have adequate nutrition for healing. And then pain, because it is extremely painful. The rehabilitative phase can take a very, very, very long time. Akron Children's is the one burn center, level 1 burn center from here to Pittsburgh. And they take all ages. So I hated working in the OR on burns. They are barbaric. It is so bloody and gruesome and horrible, and I hated it every time I had to do it. But you have patients even years and years and years and years later that are having scar revisions, laser treatment to their scars in the OR. So for rehabilitation, you want to preserve as much function as you can for the person. If they have really bad scar tissue buildup in the elbow, in the hands, in the fingers, in the knees, in anywhere that is like a movable joint, that scar tissue is going to really truly affect the function of that skin and the part of the body. Cosmetics, of course, because I mean, unfortunately, we all care about what we look like. And psychosocial support, because I mean, if you have extensive burns, especially on your face or anywhere on your body, it's really hard for these patients mentally. So we've all heard, hopefully, of stop, drop, and roll. You can use cool water on a burn. So the only ones you don't want to use cold water on is frostbite and chemical, but you want to use the water after you have neutralized the chemical burn if it's caused by an acid. Okay, does that make sense? Like, you need to neutralize it first before you put water on it. Okay. You don't want to use ice because that will vasoconstrict and increase the what am I trying to say? The potential for injury. Remove the clothing and all jewelry rings immediately. You never want to have like a piece of jewelry become a tourniquet and then lose your finger because you didn't take your ring off, because burns can cause rapid swelling. And then you want to clean the area. You want to use a dry cloth to minimize air contact because that increases the pain. Inhalation injury, you want to make sure that you recognize these. So soot around the mouth and nose, singed nose hairs, facial swelling, and then like I said, the throat will show you either redness from the smoke inhalation because of the irritation. And then they can also have like soot that is like you can see in the airway. Okay. So here is where you see the rule of nines. And this is the way to rapidly estimate total body surface area and to be able to calculate the fluid resuscitation. This is very important, especially the fluid resuscitation. Okay, so make sure you put a big fat star on this next slide. Okay, when we estimate the rule of nines, it's important to know that the neck and face is, oh wait, let me make sure. Where's the other slide? Hold on. There's some gnarly pictures on this other part. Hold on. Okay, In Notebook LM, let me share this tab instead. Can you see my screen?
Yes.
Oh, can I make this bigger? Okay, this is in the Notebook LM, and it's part of the Burn PDF, like the source, like the actual source that we're using for class. So the head and neck in total, and you have to remember that there's an anterior and posterior. So head and neck is 9% in total, but the front is 4.5, the back is 4.5. It's the same with the arms. The front of the arm is 4.5. The back of the arm is 4.5. Okay. The trunk, it's 18% on the front, it's 18% on the back. Okay. So with a total of 36. So you have a total and then you have the anterior and posterior. So make sure you pay attention to that. So each leg can be 18%, but the front is 9 and the back is 9. So if you have a burn on your right anterior thigh, what number would that be?
Would it be 9%?
9%? No.
No,
No,
because I'm
because
only
the thigh
using,
is 4.5.
it would be 4.5 because it's only half of the front of the right leg. Does that make sense? So I only burned the right anterior thigh. If I burned the anterior of my entire right leg, it would be 9%. Half of it on the anterior would be 4.5. You see where I'm going with this?
Yes.
Okay. And we'll practice this a little bit more. Okay. Oh, here we go. So, fluid resuscitation. This is very important. Very, very important. So, total fluid. Oh, I'm sorry. It's the total body surface area times the patient's weight in kilograms times 4 milliliters. So, for example, I weigh 165 pounds. So 165 divided by 2.2. Oop, that's not 165 divided by 2.2 is equal to 75. Okay. I have a burn that takes up my entire circumferential right leg. Okay. It also is my right anterior forearm and half of my anterior right abdomen. Are you guys writing that down?
Yes, I am.
Okay.
Yeah, just looking for a different color pen.
So, what percent would be my entire circumferential right leg?
I want to say 9%. Because you said it was the whole leg, right? Or is it just the anterior?
Nope, circumferential.
Okay, so
18?
9%.
Let's go back to this page. So what is the entire right leg?
9%.
9%.
18.
No, it's
No, it's
18.
18.
My entire circumferential, which means all the way around. Circumferential is all the way around, front and back. So that would be 18%. Now I have the right anterior forearm. So my entire arm is 9%, the whole arm. I only burned a quarter of it because it's
So it's
only my forearm.
I wrote down 2.25%.
So I would use the 2.25. Okay, rounding doesn't really matter much here. Okay, because truly it's an estimate. So my right anterior forearm, if my entire arm is 9%, then I need to divide 9 by 4, which gives me 2.25. Does that make sense? Does everybody understand how I got that?
Yeah.
No.
Okay.
So can you
No?
start over? Sorry, no.
Start
'Cause
over
you-
completely or just
So
the
you-
arm?
Just your arm. So how much did you burn?
Okay. Can you see my little guy here? My little picture guy?
Can you let Kiera in before you continue?
Yeah.
What?
Oops.
So just to confirm, you burnt one whole leg. That was 18%, correct? And then you say you
Yes.
burnt how much of your arm?
My right anterior forearm.
So your right arm interior.
But
One second.
only my forearm, not the whole arm, only my forearm. My forearm
So that's
is
1/4 of
only,
9.
huh?
So that's 1/4 of 9 since it's 4 parts to make it 9, but it's only one of the 4 parts that's burned.
Correct.
Okay.
Okay, I see. So you can divide the 4.5 into 2, right?
Oh,
And then you got
absolutely. Oh,
2
absolutely. Yeah.
Okay.
Yeah. Okay. So now my last part, half of my anterior right abdomen. Okay.
I said 4.5.
So let's think about this. We have, and I just made these up on the fly, so I'm also figuring my part out. Okay.
So that'd be 9.
So the whole from neck down to genitals is 18% on the anterior and 18% on the posterior. So neck to genitals, right? So I'm only looking at my abdomen, which is 9% according to my picture, right? But I burned half of my anterior right abdomen. So Sarah, I believe that was Sarah, right? Yes, you are
Oh,
correct.
so it
It
would be
would be
2.25.
no, you were right. Half
Oh.
of my anterior of the right abdomen, because the whole anterior of my abdomen is 9%,
Yes.
but I only burned half. So it would be
So
4.5.
4.5.
Yes. Does everybody see how we got there?
Yes.
So altogether, do you have 24.75?
I don't know. I didn't add it yet. So 18 plus 2.25 plus 4.5 is 24.75. Did everybody get that?
Yes.
Okay. So now, oh, was I not sharing the right tab? Which freaking tab am I sharing? I'm getting confused. Which screen are you
see the
looking at right now?
Notebook LM.
Oh, okay. So I need to change. Why isn't it giving me the option to change? I want to stop. Stupid. I hate computers sometimes. Come on, share. Okay, so we have our total body surface area percentage, which is 24.75 times my weight, which is 75 kilograms, times 4 mLs. So that would give us 25 times 4. 7,000. Oh, my pencil broke. 7,425 milliliters, which is a crazy amount of fluid, right? It's a crazy amount of fluid. Like, I'm literally telling you, you need to give me 7.5 liters of fluid in the first 24 hours. Like, that's crazy, right? Yes, Jessica. Yes, that's crazy. That's a lot of fluid. That would cause flash pulmonary edema or congestive heart failure for any human, right? But not when it comes to burns. And that's why it's so specific. So in the directions, it says give 50% of the total volume in the first 8 hours. So the first 8 is going to be
3,712.5.
yes, 712.5 mLs in the first 8 hours. What is that milliliters per hour? How many
464.
Does everybody understand how she got that?
Can you repeat it again?
Should I get my pen out and write this out so you guys can see it? Would that be helpful, or are you following along?
That would help. Miss
Okay,
Jessica,
so
please.
in order for me to do that, I have to. Oh no, I can do it here, I think. All right, so in order for me to do that, I need to get rid of my split screen so I'm only looking at one screen, okay? So I will not be able to see your chat. Okay? How do I get rid of my split screen? Separate views. Okay. Okay. Okay, so my total body surface area was 24.75%. Woo! Go back. Okay. Percent. My weight is 75 kilograms times 4 milliliters equals 7,425 milliliters per 24 hours. Okay. So it says I need to give 50% in the first 8 hours. So divided by 2 is, was it 3,712.5
712.5.
milliliters over 8 hours. So how many milliliters per hour would be you dividing this 3,712.5 divided by 8? Okay, which would give you milliliters per hour, 464 milliliters per hour. Now, if you wanted to really split hairs and say it wanted to tell you that they wanted you to round to the nearest tenth, it would be 464.1. Okay. So the remaining, 16 hours? So this is the remaining 16 hours. You give the rest of the 50%. So that means 3,712.5 divided by 16 hours. So our milliliters per hour for 16 hours would be 3,712.5
232.
divided by 16 is 232 milliliters per hour. If you are rounding to the nearest tenth, it would just be 232 because it's 232.03125. It would just be 232. Okay. Does that make sense to everyone?
Yes, when seeing it like this is better than just hearing it.
For sure. For sure. But I want to make sure everybody gets it because you will be seeing it on your exam. Okay?
Quick question. So when you got the like you did the 24 hours, you divided by half, then you divided by the 8 hours, like where did the 8 hours come from?
The 8 hours is that half of the fluid is given in the first 8 hours. It says give
Okay.
50% of total volume in 8 hours.
Okay, I didn't see that 8. Okay.
Mm-hmm. Teddy, shh. Go lay down. Okay, so then give the remaining 50% over the next 16. 8 plus 16 is 24. Okay. Everybody okay with that? We can do a couple more in a little bit. Also,
Yeah, I think that,
let's do
you know,
this too. Let's do this. So remember I said 18, or I'm sorry, the entire circumferential right leg. So let's just say this is right, this is left. This is right. No, I guess it would be the opposite, huh? And this is left, this is right. Okay. So my entire right leg. I really should have made that red, huh? And the posterior, including the buttock. Okay, so we have 9 and 9, which equals 18, right? Does this help seeing the visual of how we got these numbers?
Yes.
Okay, so if my abdomen is 9 and 9, and remember, the genitals is separate, this is its own 1%, and I only burned half of my right anterior abdomen. And then I only burned this okay. So if this whole part is 9, that's how I got my 4.5. And this is a quarter of my arm, which is how I got my 2.25%. What do we think about that?
Okay, so if the whole arm is 9%, right?
Mm-hmm.
So then why is half? Is it just like the forearm? That's you're showing this 4.5, or okay.
Yeah, I only burned the right anterior forearm, which I guess is that, yeah, that would be anterior. Yeah. So let's do one that's a little trickier.
Wait, that's confusing to me because if the whole arm is 9,
I
wouldn't
only
the
burned a
4
quarter of it.
But wouldn't that be 2.25 instead of 4.5?
That's what I said. The 4.5 was going to the abdomen.
Oh, okay.
Okay. All right. So let's make it a little bit harder. So I burned my right butt cheek. And my right trunk. My right hand. And okay. So if the whole posterior of my right arm is 9%, and if I divided my arm into, this is half, this is a quarter, and that's a quarter. Well, maybe like that's a quarter. Okay. And I only burned that part of my posterior of that arm. What would that be? So my whole arm front and back is 9, right? 9 divided by 4 is what? 2.25.
2.25.
So, and we learned over here, 2.25 would be all the way down, right? That's 2.25. So what is this? It's not a trick question, I promise. It's as easy
Would
as
that
you
be
think
like
it is.
1.125?
Yes. 2.25 divided by 2, which would be 1.125%. Okay. So now I'm looking at my right butt cheek. If my leg, the whole back of my leg is 9, and this is half, this is a quarter, and this is a quarter, what is my right butt cheek?
Is it 3%? Point?
I think it would be the 2.25.
Correct. Okay. Now, what about the trunk? My half?
I would say 9%.
Correct. This would be 9% because the whole back is 18 and I burned half of it. Okay. So now, what was my head and neck?
Head and neck is a total of 9, so it'll be half of the neck would be the 2.25. No, wait.
So, wait a second. For the entire head and neck is 4.5 on the front, 4.5 on the back. right? Because it's the whole entire body part is 9. But the posterior and the anterior are 4.5, correct?
Yeah.
Okay.
Right.
So if I only burned a quarter, oh, I guess kind of overdrew that a little bit.
Is that
I
still
only
1.125?
right, a quarter of the back of my neck.
So is that the 1.125?
Mm-hmm. 1.125. Does that make sense how we got all of those numbers?
Yes.
Does anybody not see it? I hope we've gotten to a point where I'm hoping that you don't feel embarrassed when you don't understand something, because I want to help you understand it.
Are we going to be using the rule of 9 on the exam or the other
Teddy.
one? Because the other one was just too much.
Teddy, stop.
Like, look at it.
Okay, so you have to understand that this is two completely different things. Okay? You have to find out the total body surface area in order to do the Parkland formula. Right?
Yes.
So are you going to have to figure out both? I don't know yet.
Yes.
I didn't finalize my exam, but I at this point am going to assume yes. I don't think I'm going to do it in picture form though. I think I'm going to do it in word form, like the way that I've been doing it. Like when I first said the entire circumferential right leg, the right anterior forearm, the half of the anterior right abdomen. So it's going to be up to you to remember what body part is what percentage, so that when you draw your little stick figure on your whiteboard, when you're reading the question and you're saying, okay, she said the right entire circumferential right leg. I know that the entire right leg is 9%. So if it went all the way around, then it's going to be a total of 18. That's what I need you to be able to do.
So I have something to say. So for the, never mind. I don't have anything to say. Okay, thank you.
Sorry, Jess. I meant, are we using the rule of 9 or the Lund and Browder? Because that's the two that was like kind of weird. But I feel like the rule of 9 works better. That's what I was asking.
Wait, where is the other one?
On our burn sheet worksheet, and we had to go over Lund and Browder as well. So I was like, that's too much to list.
Yeah, no. The rule of
Okay.
nines is the gold standard.
Okay.
Yeah. And so is the Parkland formula. Yeah, I didn't even recognize that word that you said. I was like, I don't know that word. Okay,
So
so
just to confirm, I'm sorry. So as far as like the Parkland formula, as far as like the 8 hours and the 16 hours won't change, correct? That's like standard.
no, that's standard. Yeah. The numbers in the formula are going to change depending on the size of the patient and the size of the burn.
Yeah, but not the 8 hours and the 16.
No, you always give 50% of the total volume over the first 8 hours, and then you give the remaining 50% over the next 16, with a total of 24 hours. So at the end of my 24 hours, I have received 7,425 milliliters. Does that make sense? That good?
I have a quick question for about the body parts, like how you then went over the arm. So is the hand just always half of the 2.25? It's not like split in fourths and you go down by that.
No, the hand is included in the in the arm. They don't differentiate the hands. They do differentiate the anterior hand and the posterior hand. So if it would have been the entire hand, front and back, then that would have,
2.25.
yes. But it was
Okay.
only the anterior. Or I'm
Okay,
sorry, the
thank you.
posterior. Okay. So you tell me what you want to do. Do you want to do a couple more of these? Do you want to do more of the rule of nines? Do you want to do more of the Parkland formula? Do you want to just keep going?
Do you
We
have
could
like
do
an
it.
extra paperwork with practice? Like just to like doing your own kind of?
Um, that's not what I wanted. Where did my, what did I just do? Oh, I think I accidentally went out of my notebook, Ellen. So this is on the notebook LM burn care quiz. So this can be a nice little extra. So according to the rule of nines, what is the estimated total body surface area burned for an adult with injuries to the entire right arm and the entire anterior trunk, chest, and abdomen? So when it says entire right arm, that is circumferential. If it's not listing anterior or posterior, then you are safe to assume it is the entire front and back arm. Okay. So what is the entire arm?
9.
Okay. And then what would be the entire anterior trunk, chest and abdomen?
18.
So 18 plus 9.
27.
And that's right. The entire arm is 9. The anterior trunk is 18. 9% chest, 9% abdomen. Or I'm sorry, that should obviously include 9% abdomen, 9% chest. Oh, duh, equals a total of 27. Okay. So a patient weighs 80 kilograms, has a 25% total body surface area burn using the Parkland formula, 4 milliliters times kilogram times total body surface area. How much fluid should be administered in the first 8 hours after injury? So it's already giving us all the information, right? So 80 times
4,000.
25 times 4 equals 8,000. And in the first 8 hours, we give half. So that would be 4,000. Does everybody understand how we got there?
I got the 8,000. Then I was trying to get the 4. Can you the 8,000? How did you get to the 4,000?
Because remember, half of the total amount of fluid has to be given in the first 8 hours.
Got it.
So
Thank you.
50% in the first 8 hours, and then the rest of the 50% over the next 16. Okay. Why do full thickness third degree burns often present with little to no pain at the site of injury?
D.
D.
Everyone agree with D? I can't see your chat, by the way.
Yes.
Okay, so that is correct. Third degree burns penetrate through the dermis, completely shooting or destroying the nerve endings located there. I don't like that they use the word shooting. It's weird. It's a weird use of the word. During the emergent phase of a severe burn, which electrolyte imbalance is most likely to occur due to massive cellular destruction?
Is it B?
B,
So they
hypokalemia.
definitely put both of them on there. And I did say when it was like a huge severe burn. So I want to see the rationale. I'm going to pick C. Okay, so potassium is primarily an intracellular ion, which we discussed. When cells are destroyed, it is released into the extracellular fluid, which is then going throughout, the circulation. So let me see if we can get a little bit more explanation. Come on. So we talked about potassium being primarily the intracellular electrolyte. We talked about that. The burn injury is that the severe burns can cause massive cellular destruction, which is lysis. We talked about that. The release. So when those cells break open, lyse, the potassium that was contained inside is released to the systemic circulation, which we talked about. This imbalance is a critical priority during the emergent phase, which is the first. Wait, what is the first phase? Is that the initial? Is that called initial? Let me see. Let me go back. Okay, so the emergent phase, is between the first 24 and 48 hours. Sorry, I just wanted to make sure that was correct and I wasn't eating my words. I don't like saying wrong things. So emergent phase, the first 24 to 48 hours. Cardiac risks, the sudden risk in potassium can disrupt the electrical conduction. Hyperkalemia contributes to the overall hemodynamic instability. It can be related to hyponatremia because we know that potassium and sodium are on a teeter-totter. So while the potassium levels rise due to cell destruction, your sources note that hyponatremia often occurs simultaneously. So unlike potassium, which leaks out of the destroyed cells, sodium is most often lost due to the massive loss of fluid through the open wounds as well as fluid shifting into the tissue. While hyperkalemia threatens the heart, hyponatremia carries its own risk, including neurological issues like brain edema. And remember, hyponatremia puts a patient at a bigger risk for seizures. Okay. Because of these massive fluid and electrolyte shifts, the number one priority in the emergent phase is fluid resuscitation. Healthcare providers use the Parkland formula to calculate the massive amount of fluid required to stabilize the patient. So what I want you to do is I want you to focus more on what happens with the hyperkalemia and not the hypokalemic is like, it's very specific to like an extremely large third degree burn. So those are very specific cases. This is talking about the most common situation. The most common electrolyte disturbance you're going to see is hyperkalemia. Okay. And this gives us a really good rationale. So are we all on the same page about that?
Yes.
Yes.
Yep.
Okay. All right. What is the primary physiological reason for performing a fasciotomy in a patient with circumferential burns?
C.
C.
Everyone agree? I agree. So eschar is leather-like. It does not stretch. There's swelling underneath. It compresses the vessels and nerves, requiring an incision to restore the flow. When providing first aid for a chemical burn, what is the most crucial initial action?
D.
A.
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 Oh, this is a really tough question. It literally lists, like, depending on how you take the information, because first of all, you don't know what the neutralizing base is unless you look at the MSDS. And then we talked about running continuous water as fast as possible, but then we're talking about a chemical burn. And I feel like I'm going to eat my words because if B is correct, I'm going to need a rationale. So what are we going to pick?
I would say
it's
pick B because we have to
B.
figure out what the thing is before we can neutralize it. Then we can treat it.
I agree. I really
yeah, I
hope
said D.
B is not correct because like I said, if it's damn it. Okay, I need a rationale. Explain. I love this notebook LM that it gives us rationales and like really like this is just so cool. Because if I used this specific question on my exam, I would have picked D as the correct answer.
Yeah, because what if the thing that's burning them is activated by water?
Okay, so the reason your answer was incorrect comes down to the immediacy of tissue damage. Okay, so I think where we're going with this specific question is not to delay. Okay, I think that is the key takeaway from this specific question. So while an MSDS provides vital information, the chemical is actively destroying the skin layers every second it remains in contact with the patient. So is it better to A, delay care and go look for a book? Because by the way, have you ever seen an MSDS? It can be a very large book, and do you even know what you're looking for, right? Or B, do you take the risk and flush it with continuous water because it could be a correct answer? You know what I mean? Like, what is going to be more of a risk to your patient? And think about it if it was yourself. This is you. You have spilled a chemical on your arm, and your arm is literally burning in front of you. Are you going to say, I need to go find an MSDS and go search around for it? Or is it going to be more beneficial, possibly hurt you, but probably help you to do something? Does that make sense? So here's the breakdown of why irrigation is the priority over information gathering. So the sources emphasize that chemical agents can continue to burn the skin even after they are wiped off, which we did talk about. Therefore, the most crucial factor in improving patient outcomes is the speed of removal. Valid. So immediate action, the lecture explicitly states that the very, very first thing to do for a chemical burn is to douse it and drown it in running water to get the agent off as fast as possible. Outcome improvement, rapid sustaining flushing at the scene significantly improves patient outcomes. Waiting to locate and read, Teddy, stop. Read a document allows the chemical to penetrate deeper into the dermis and hypodermis during that delay. The standard of care for first aid described in your materials follows the specific order to minimize injury time. Number 1, brush off. Teddy, I'm gonna fight you. Brush off the agent if it's dry powder, brush it off first. Number 2, remove clothing immediately while rinsing. Number 3, Teddy, you better stop. If you wake him up, I'm gonna fight you. Teddy, come here. Continuous irrigation, rinse all areas in a shower under continuous running water. And number 3, the role of the MSDS. You are not entirely wrong to think of the MSDS as it is an essential part of the workplace safety. Facilities are required by OSHA to keep these blah, blah, blah. However, in an emergency first aid scenario. So the key takeaway is that you should not delay the physical removal of the chemical to consult the paperwork. The priority is to stop the destruction. in the emergent phase of a chemical burn, mechanical removal, flushing, irrigating always takes precedent over administrative tasks, which makes sense. I was thinking that what if the water made the chemical reaction worse, which is possible with some chemicals. But I'm going to say that probably the amount of chemicals that get worse with water is a very small amount compared to the ones that don't. Are we all on the same page about this? Shh, shh.
Yep.
Okay, does anybody have any questions about this specific situation?
I know when I was working in EMS, they told us to brush off as much of the chemical as possible and then drown it and just continuously do it until we get to the hospital.
Okay, because then you have time to research whatever.
And because we may not always have access to the MSDS.
Very correct, and you don't want to delay care. Okay, I'm glad we did this. Okay, which objective finding is the most reliable indicator that fluid resuscitation is successful in a burn patient?
A.
Does everyone agree?
Yes.
Yeah. Yeah.
I agree. So adequate urine production demonstrates that the kidneys are being perfused, reflecting sufficient systemic circulating volume. Why must nurses avoid applying ice directly to a large burn area during initial treatment?
C.
Does everyone agree?
C.
I agree.
Yep.
I agree. So ice constricts blood flow, can damage fragile tissue, while large-scale cooling can rapidly drop the core temperature of the patient who cannot thermoregulate. Don't forget that thermoregulation. What is the defining characteristic of the acute phase in burn management? I want to get more information on this one too. There's
Is it
only one
D?
option. It has to be C. The only option is C. And I want to know about the diuresis. So I want it to explain. Because if you're massively fluid resuscitating someone in the first 48 hours, specifically the first 24 hours, then the acute phase is 48 to 72 hours. Why then would you diurese after you have just resuscitated? So here, that's where my brain is going. So here is a deeper look at why this phase is distinct and what the priorities are based on your sources. So time frame, the acute phase begins 48 to 72 hours after the burn injury. The start point, diuresis. During the previous emergent phase, the capillaries were leaky, causing fluid to shift into the tissues, which we did talk about edema. The acute phase begins when capillary integrity is restored. The body then starts to shed the massive amount of fluid retained during resuscitation. So when they were speaking of diuresis, we are not giving Lasix to diurese. The normal body response is to diurese. So I took it the wrong way. When I saw diurese, I was like, why would I diurese my patient? That's dumb. Why would I do that? But this is saying that it's your body's natural response, that when the capillary integrity is restored, then the body will start to relieve itself of that massive amount of fluid. Does that make sense?
Yes.
Okay. So the endpoint, this phase continues for weeks or months until the wounds are either healed naturally or surgically closed via graft. Clinical priorities in the acute phase, while emergent phase focuses on keeping the patient alive. which, yes, valid. The acute phase focuses on healing and maintenance. Wound care and infection control, it has up to a 50% or more of the body's surface open and weeping. Preventing infection is a massive priority. Debridement, this phase also involves the removal of eschar, which is dead, leathery tissue, which we also refer to, oh, it says debridement. We refer to this as a debridement because healthy tissue cannot grow and grafts cannot survive until the dead tissue is removed. That is very, very, very important. Grafting, we didn't get to this part. So full thickness burns, the wound cannot heal on its own. There has to be some type of surgical intervention. So this phase includes either autologous skin graft, so this is using the patient's own skin, or there's a new product which I talked about in the video. It's called RECELL. We use it at Children's, and we're one of the first hospitals in the US to start using it, and it is like a spray on skin. It's very, very cool. And it's the patient's own skin cells. You can also use cadaver skin, but a lot of people don't know that cadaver skin, which is dead skin coming from a dead human, it is not a permanent replacement. Cadaver skin is only there to put something over top the wound to help with thermoregulation, to help with the healing process, but it must be removed. You cannot put a cadaver skin on a burn and leave it there. Okay? A lot of people don't know. I didn't know that going into the OR, into burn surgery. I did not know that. I assumed that you could use cadaver skin just like you could use autologous skin grafts. You cannot. Pain in this phase is described as generally severe. Your sources categorize the pain into 3 types. There's background or resting pain, which is constant pain while at rest. Procedural pain, which is pain caused by dressing changes or wound care. Breakthrough pain, spikes of pain that occur despite medication. And then treatment includes opiates, which are the standard of care, and because it is extremely painful. Nutritional support, we talked about how important this is. Think about when we've talked about hyperthyroidism and how like high the metabolic rate, the metabolic demand of energy, of cellular production and everything your body is doing. It is, think about that times 1,000 when it comes to your body healing from this type of injury. So it is extremely hypermetabolic, meaning we need more energy to heal. And then malnutrition, of course, we already talked about protein intake. Okay. In the case of an electrical burn, what is a secondary complication that the nurse should monitor for beyond the skin surface damage?
B.
I feel like this is
B?
a really easy question. Yes.
That B?
Yes. So the electrical current disrupt the body's internal conduction system, which can cause the heart to stop or beat irregularly. Very good. Go back. Okay. Let's see. This is cool. This burn classification and assessment profile. Burn care management study guide. So it gives you 10 questions and an answer key. Also goes over a glossary of key terms, which is really cool. We just did this. Let's go to the bottom. Let's see if we, so acute phase management, we pretty much just talked about this, but this is the first time that we talked about the pain management. Restoration, we talked about this. So autologous, you use your own skin, spray on skin, can be very helpful. Cadaver skin is only temporary. And then we have long-term rehabilitations. You want to use pressure garments because they prevent the scarring and keloids. Physical therapy, you want the prevention of contractures. Contractures is when your body is held in one place. So, and which is, can be caused by the tightening of that tissue and the hypertrophic scars. So if your arm is so severely scarred where your arm is always at a 90-degree angle, you're never going to be able to completely extend that arm unless that scarring is reduced. So do you guys want to go through this case study or do you want to move on?
Move on.
Okay, everybody good with that?
Yeah.
Okay. So, did we say that a lot of us, how are you guys finding the notebook LM slides? I can't find the slides we're looking at.
I found it, Jess, in the emails.
Oh, good. Okay. The notebook LM1 is contraindicating the other PowerPoint that breaks down anterior and posterior percentages. What do you mean? Oh, wait, she can't see the chat. I sent you a message. I gotta get on PowerPoint. Okay. Tonasia, what do you mean? Or did she leave? Did she leave me? I lost 3 people. Wow. Am I that boring? Sorry. Well, I mean, we have to go over
It's
it
not
because
that
if
it's
we
boring,
don't
it was
ever
just
go
like
over
hard
it,
to follow.
you know what I mean? Like I can't put something on your exam that we never went over. Like that, I don't like doing that. You know what I mean?
No, and that's fair. I just don't comprehend well by hearing number stuff.
Okay, but
So I like had to watch.
I feel the same
I don't
way.
know if anyone else felt like that too.
but were
did,
you
yeah.
able to understand it better when I was writing it out?
No.
Yes.
I'm gonna
I
Google
did. That worked better for me just to see it. Now I understand it.
Okay. Because this may be the only opportunity we have for this. So
It is a little tricky. So in real life, like in Epic, when you put that on there, all that will already calculate, correct?
I have no idea. I have no idea if, no, that is calculated by a physician and EMS. So say you are in a house fire and you have 57%, I've just random number, 57% of your body is burned. EMS is going to call the department, their ED they're going to and say, hey, I have a patient that has over 50% third-degree burns to their body. So when EMS arrives, the attending physician already has an idea of what's coming. And then when that patient is admitted or when that patient is brought in, they will have a chart, like a picture of the human body in the chart where they will label exactly where the burns are and then give an estimated total body surface area. So no, Epic does not do this for you. This is done by the provider. As nurses, it's important for us to be able to understand the fluid resuscitation. And we can't understand the fluid resuscitation if we don't know how to figure out the rule of nines. You understand what I'm saying?
Yeah.
Okay. So, I mean, and I'm not trying to be like any type of way. But like, if this is not helpful, then I don't want to keep doing it. You know what I mean? Because if I'm not being helpful, then I could be putting my energy towards something else. You know what I mean? Like, your girl's got a lot of homework to do. I have a final to finalize. I have a whole simulation that I need to prepare for you guys for the next 2 days. Like,
It was very helpful to me to see it written out. So I appreciate it. Thank you.
okay,
Yes, it
because
helped me too. I appreciate it.
okay. I mean, if you don't feel like, and I'm really not trying to be a jerk here. I'm really not. But if this is not helpful for you, you do not have to stay. This is voluntary. Okay? Like, you do not have to be here.
It helped me
I
understand it
think the
more.
whole thing, I just get confused hearing numbers, but like other points and stuff that were made, like going through this stuff was really helpful.
I mean, the math is definitely confusing, but I need you to, and that's why I was trying to write it down, is that so you could actually see it instead of me just saying numbers. Okay? I am not giving key points, Lisa, right now, today. They will
They're
be
key
coming, but
points
it's
for my
not.
personal notes. They're key points for me for my personal notes. Things that I may have missed when I took
Oh, I agree.
That's why I
I
stayed,
agree
because
with
there
you
might be something that I
100%, Miss
missed.
Lisa.
Yes.
Yeah, no, I agree with you 100%. But like, specifically key points for the final, I will not be doing that during this video. Like, I'm just trying to go
This
through
is
stuff
just
that we
key
never got a
points.
chance to go through.
Key points for the notes.
Which is why I'm hoping that every one of you can look at it that way, because that's all I'm trying to do, is to help you have a better understanding. Okay? So, we went over shock in class. We did not get to go over trauma or disaster. Do you want to go through that? Do you want to do questions? Tell me what you want to do so that we can best utilize our time. Because you guys all know that I can sit here and talk for a very long time.
Maybe some questions just to see if the lecture got into my brain.
Okay, so disaster study guide, study questions.
I'm
Yes,
just
that's
starting
fine.
on disaster, so yeah, that may be beneficial. I'm just now
Okay.
starting on,
Disaster.
on the trauma portion. Yeah.
It looks like this might have combined sepsis and disaster in this one. Okay, so a patient is being evaluated for systemic inflammatory response syndrome. Which of the following vital signs would meet the criteria for SIRS? Does anybody remember the criteria?
Temperature,
Mhm.
heart rate above 90,
Mhm.
respiration above, I believe it said 20.
Mm-hmm. And then white blood cell count over 12,000 or lower than 4,000.
Mm-hmm.
Was it 12? I thought it was like 20.
No, well, the PowerPoint said 12.
It says 12?
Mhm.
Okay.
More than
Okay.
12,000 or less than 4,000.
I
Okay,
want to say
okay.
the answer is B.
I agree. I believe the answer is B. I just wanted to go through those signs of.
No, that actually helped.
Yeah, good. So Sears criteria are met when 2 or more signs are present, including the heart rate greater than 90 and a temperature greater than 100.4 degrees. Okay, so with these coming questions, you're going to have to know what these surveys mean. So during the primary survey of an emergency assessment, which action is categorized under D, disability?
Your blood glucose.
I want to say A.
Oh, listen,
A.
I'm not looking at the questions. I was just answering.
So are we agreeing that it's A? I'm not helping with this. I'm gonna let you guys lead this.
I agree
Yeah,
with A.
Yeah.
Okay. So A is correct. The disability phase focuses on neurological status, including the level of consciousness, pupil reactivity, and the motor response. Okay. What is the primary clinical difference between a patient in the Sears stage and a patient diagnosed with sepsis?
I wonder if there's any way I can make this bigger.
D.
You should be able
I
to
agree.
zoom your screen, Lisa.
I think it's D as well.
Yeah, D.
Okay, I agree. That is correct. Sepsis is defined as meeting 2 or more Sears criteria, specifically in response to a known or suspected infectious process. Why is it not C?
I'm not sure. That's the two I was bouncing between with C and D.
So the answer is not C because C is septic shock. And there's a difference between stage 2 of sepsis and stage 3 of septic shock. Okay. In a mass casualty incident using the START method, how would you tag a patient who is unable to walk, has a respiratory rate of 24, a present radial pulse, but cannot obey simple commands?
Red.
I would put them in red.
Okay. Does everyone agree with red? Okay, so according to the START method, if a patient has adequate breathing and circulation but exhibits altered mental status, they are tagged as red. So red is going to be immediate. Okay. Make sure you know these colors and what they mean. A patient presents to the emergency department with a silent airway and stridor after a bee sting. According to the emergency severity index, what level should they be assigned? So in my opinion, just to help you out a bit, so we have to understand that this is a severe situation, right? The patient is having an anaphylactic reaction. They're having stridor after a bee sting. Stridor means that air is having a really hard time passing in and out of the trachea. Okay. So if we didn't know the levels, we could at least say this is an emergency. This is a very bad thing. And it's either going to be level 1 or it's going to be level 4. If you didn't know which one was the worst and which one was the best. Which
I want to say 1.
I hope it
We'll
doesn't
say a
make
level
any
1.
I want to go with 2.
You said you want to go with level 2?
Me too. I'm going with level 2.
Yes.
Ooh, so maybe I'm wrong. All right, 1 or 2, 1 or 2. A or C?
A.
C. Or, I'm sorry, A.
Oh, I hate when I'm wrong. See, I would have got it wrong. Level 2 emergency includes time-sensitive situations like stridor or chest pain where the patient must be seen within 10 minutes. Okay, explain. because first of all, that sounds crazy to me. See, Jessica isn't always right. I never claimed to be. But I really feel like a silent airway and a patient in active anaphylaxis sounds pretty emergent.
Wouldn't a level 1 be the comfort care only though? Like that emergent but comfort only, like they're not expected to survive. So that's why it would be a level 2, like they have to be
No,
seen
it's
now.
not comfort. I mean, yes and no. So because the only reason it's a level 2 is because a level 1 is a cardiac arrest. That makes sense. Level 1 is your patient is dying right now. Level 2 is your patient's going to die in 10 minutes. Level 3, they might die within an hour. So that makes more sense. I wasn't thinking about resuscitation. So does that make sense for everybody? Why level 1 would be cardiac arrest, like you're dying right now. Level 2, you have maybe 10 minutes.
Because they're having some form of airway still, even though they're going to die really soon. But is that why?
Correct. So with a level 2, you have impending something, impending loss of airway, impending MI, say it was a chest pain, impending, obviously we know that time is imperative when it comes to all of these things, which include stridor, chest pain, or stroke. So, but we still do have time. You have time to intubate. You have time to give epi. You have time to get the patient to the cath lab. You have time to get the patient to CT to see if it's embolic stroke or a hemorrhagic stroke, right? When your patient is cardiac arresting or in a state of shock where they're hemorrhaging or something, like they require you to save their life right now. There is no time. Good. Okay, regarding the nursing management of sepsis, what is the most critical rule concerning blood cultures and antibiotic administration?
Get the cultures, then administer the antibiotics immediately.
So the answer would be D. D as in dog.
D as in dog is correct. The standard is to draw cultures before the first dose, but life-saving treatment should not be stalled by logistical delays in the lab. Never delay. What is the primary purpose of maintaining a MAP greater than 65 in a patient with septic shock?
B.
Does everyone agree with B?
Yeah.
Yeah.
Okay. So a MAP below 65 indicates that perfusion pressure is insufficient to deliver oxygen to major organ systems, leading to failure. During the secondary survey, a nurse uses the mnemonic sample to obtain a history. What does the L represent in this context?
A.
A.
Okay, everyone agree?
Yeah.
Okay. Knowing the time of the last oral intake is crucial for assessing aspiration risk if the patient requires emergency surgery or intubation. Would you like to hit the explain button and look at all the letters?
Yes.
Sure.
Okay, so to complete the sample mnemonic, we have S is for signs and symptoms. What brought them in today and what are they complaining of? A is for allergies. Are they allergic to latex, eggs, nuts, or specific medications? M is for medications. What did they take at home? P is for past medical history. Do they have underlying conditions? L is last meal. When was the last time they had any oral intake? And E is events. How did the injury or illness occur? What were the circumstances? So the sample history is part of the secondary survey, which occurs after the primary survey, which is the ABCDE, which is when it's complete and life-threatening issues have been addressed. So while the primary survey focuses on immediate survival, airway, breathing, circulation, the secondary survey is about gathering the full picture, getting a full set of vitals, giving comfort, and performing a head-to-toe assessment. Okay. Which of the following describes the late stage symptoms of septic shock as opposed to the early stage?
C.
I agree with C.
Okay. I agree as well. In the late cold shock phase, the body shunts blood to the core organs, leading peripheral vasoconstriction and kidney failure. Very good. A nurse is caring for a patient who ingested a corrosive poison. Why might the nurse administer milk based on the source material?
A.
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 I agree. Milk can act as a buffer for certain corrosive toxins to prevent the mucosal lining of the GI tract. Yes. In the START triage method, if you reposition a non-breathing patient's airway and they still do not begin to breathe, what is the next step?
B.
I agree.
Okay. Everyone agree?
Yes.
Okay, so if a patient remains apneic after the airway is opened in an MCI, they are considered deceased or beyond help with available resources. Would you like to go to the explain or no?
Yes.
Okay. So START stands for Simple Triage and Rapid Treatment. So the START method is designed to evaluate a patient in less than 30 seconds. Number one, check for breathing. Breathing is present, you immediately check the rate. If it is greater than 30 breaths per minute, tag red. If it is less than 30, move to checking circulation. If breathing is not present, you do not tag them yet, you must attempt to open the airway. Number two, reposition the airway. Perform a manual maneuver, chin lift, jaw thrust to remove physical obstructions like the tongue. Scenario A, if they gasp or start breathing after you move the jaw, they are tagged red, which is immediate. They need immediate medical attention but have a maintainable airway. Scenario B is if the chest remains still and no air moves, they are tagged black. You leave them and move on. The summary of START triage tags. So green is minor. This is the walking wounded. Any patient who can stand up and walk to a designated area upon command. Yellow is delayed. It's serious but stable. ABCs are stable. They can follow commands, obey instructions, but they cannot walk. So maybe they have like a broken leg or something. Red, this is critical life-threatening, requiring immediate intervention. There is criteria. So if the breathing is greater than 30 or only breathes after airway prepositioning, and then if there is no radial pulse or unable to obey commands, whether they are unconscious or confused. And then black is that they are dead or dying, no respiration, even after airway repositioning. So it's hard to understand the kind of like mental state that a person has to be in this type of triage situation. But this is a truly mass casualty event. When you see this person that is still alive but is tagged black, and they're tagged that way, yes, it's very sad and it sucks, but it's the rationale of, am I going to take away from people that can live to waste, and waste is a terrible word, but wait, for the moment, waste resources on a person that may not survive even if I do put in an airway. Okay. So it sucks and it's scary to even think about being in a situation like this. But when you're in mass casualty situation, you have to be able to think like this to save the most amount of lives. Okay. What does multiple organ dysfunction syndrome represent in the progression of shock?
B.
I want to B.
Okay. B is correct. MODS is severe sepsis / shock. I'm having a hard time with my S's today, where organs like the kidneys, liver, and lungs shut down due to prolonged lack of perfusion, which is why it is in the it's past sepsis stage 2. According to the source material, which of the following is the standard fluid resuscitation volume for a patient in sepsis? So this is not Parkland. This is sepsis. What happens if we hit hint? This weight-based calculation is mentioned as the protocol used for the case study patient Mr. McMillan.
I almost want to say C.
Okay.
That's where I was leaning towards.
Okay. So everyone agrees? Let's find out. The answer is A. Current sepsis guidelines recommend an aggressive initial fluid bolus of 30 mLs per kilogram of isotonic fluids to restore intravascular volume. A patient is identified as having a tracheal deviation during the primary survey. This finding is most indicative of which life-threatening condition?
C.
C.
Tracheal deviation is a hallmark sign that pressure in the chest cavity is pushing the mediastinal structures to the opposite side. Which nursing intervention is prioritized during the exposure E phase of the primary survey?
B.
Okay. Everyone agree?
Yeah.
Yes.
Good. So after removing clothes to assess for injuries, it is vital to keep the patient warm to prevent the trauma triad of death, which includes hypothermia. Do we want to go into explaining this, or are we good on that?
I'm okay on it. It actually says that on the PowerPoint.
Good. Okay. All right. What else do you want to do? We have disaster nursing protocols, study guide, which comes with answers. We can go to this one. We have nursing. This is the one we were just on. We have the burn management. We have shock pathophysiology that we didn't look at all. We could go over the EKG thing if you guys wanted, the one that I sent. We could go over the worksheet. Let me see that email. I attached some type of worksheet, study worksheet. Where it goes all the way through ABGs down to EKGs, assessment
We
of
could do
oxygenation.
EKGs. Nobody mind. I don't mind.
It's one, I mean, I would like for you guys to all agree on what you want to do next.
I'm always down to go over EKGs.
At
I'm
this
down for
point,
whatever.
going over anything is going to be a help. So I'm going to go with whatever others say.
Okay. Let's see if I can use this. I accidentally exited out of my email. So there's a website and there's also a practice test thing. Did you look at them? Which one do you want to do? We could try one, and if you don't like it, we could go to the other.
Let's do that.
Yeah,
Okay.
that'll work.
So go to a website first. So this is rhythm strip flashcard practice. So once you guess, we flip over the card and see if it's correct. And there's like a crazy amount of these. Oh my God, there's so many. There's 177. A lot of practice. So, we can do a couple good ones. So let's see. What is number 4?
Is it SVT?
Everyone agree?
That's what I would say.
I agree.
Yes.
And what do we treat SVT with?
Bear down.
And then?
The basal maneuver.
Then?
Cardioversion?
No.
Adenosine.
Adenosine.
Okay.
And what does adenosine do?
Bring down the heart rate.
It stops it.
I say it turns it off and turns it back on again.
It literally turns it off, turns it back on. Yes. What is number 5? And what is the difference between 4 and 5?
It looks like
Is
VTAC.
spacing?
No. So what does SVT have? SVT has a rate of what?
Is that tachycardia?
Like 150 to 200? Is that the one?
151 to 200. It's regular, right? And it has no P wave. Okay. Is this next one regular?
Yeah, it looks like it
Yes.
Mhm.
from what I can
Do you-
see.
Do you have a P wave? May look a little different than what you're used to.
I think
It
so.
looks like a P wave.
Yes.
Yeah.
Yes,
Yeah, I
it has a
think
P wave.
so.
And what is your rate?
130.
Okay. So I have a P wave. It's a regular rhythm with a rate of 130. The only other thing I could do
Tachycardia?
is
Sinus
right.
tachy.
Agreed. So the only other thing I could do is measure my PR interval and my QRS. Okay. But this is sinus tachycardia. So everything is normal except for the rate. Okay. What is, let's see if I can make this bigger. Oh, yeah. What is number 7?
Is that
Looks
just
like a normal sinus rhythm.
Yeah, that looks like normal sinus.
That is correct. Good. Okay. What is number 10?
is that Brady?
Brady.
That is sinus bradycardia. Okay. What is number 12?
Is it sinus tachy?
I agree. The PR interval is normal. The QRS is normal. It's a fast rhythm. I have a P wave. So everything is normal except for the rate. Okay. What is number 19?
Would this be a heart block?
I would say that looks like a heart block.
Okay. Which one?
Second degree type 2.
Yeah, second degree type 2, the Mobitz.
I think it's a third degree.
Mm-mm.
I always pick third degree.
What are my 2 questions that I need to ask myself?
Does it have a P wave?
P wave.
Okay, I have a P wave. So when we're specifically talking about heart blocks, my first question is my PR interval constant or is it getting progressively longer? So if we look at this third beat, we have 1, 2, 3, 4 boxes. On the fourth beat, we have 1, 2, 3, 4, 5, 6 boxes. On the fifth beat, I have 1, 2, 3, 4, 5, 6, 7, 8. So what is my longer drop?
Second degree type 1.
That's the winky bot.
Now I have a
Winky bot.
winky bot. So I will say the first couple beats were a little misleading. I think that if it would have kind of kept on going with this trend, the way that it looks in the first 2 beats and then the drop here, and my PR was kind of all over the place, it could have been a third degree. But because these last 3 beats are a longer drop, that's how I can establish that this is a second degree type 1. Because we're just missing, this is the second beat here, this is the third beat here, this is the fourth beat drop. We're missing that first P and QRS. for the Winky Bach when you're looking at that first two beats. Do you see that?
Yes, that's why I picked the Mobits.
Mm-hmm. What is number 21? What
For
is
some reason,
happening?
I'm
What is
PVC, but I
happening
don't
on
know.
the fifth beat?
Sorry, are we looking at 21?
Mm-hmm.
No, I
Okay.
want to say that's a third degree, but I don't think that's right.
That's PVC. This is sinus rhythm with a premature ventricular contraction. Everything is normal. It has one beat that is a premature ventricular contraction. It is followed by a compensatory pause. And this one beat is a PVC. The rest are completely normal.
Okay, so that's what I thought it was, but I don't see PVCs on the PowerPoint. Are they gonna be on the test?
No, I just need you to know what they. I have said this a couple times. I just want you to know what they look like because this is the most common arrhythmia you are going to see every single day as a nurse.
Okay, 'cause I have a PowerPoint. That's why I knew what it was. Okay, thank you.
And that's okay. It's a valid, very valid question, but I need you to be able to recognize them because it is so common. You could be having one right now. That's how common it is. What is number 25? Oh, I don't know if I like that one. We'll try it anyways.
Is it VTAC?
No,
Sinus tacky.
no. Do you see a P wave? Is it regular?
Oh, this tacky, ventricular tacky. Is that what it is?
No,
Nope.
it's irregular.
This is atrial flutter with varying conduction.
Oh, I'm sorry. I was looking
Now-
at 20.
26 is also not VTAC. So number 25, is atrial flutter. Remember, we talked about what it looks like when things are inverted, meaning it's upside down. So these QRS waves are inverted, which means it's probably coming from a different lead. So I could understand if you were to pick AFib for this because it's irregular and it's chaotic. You don't have a discernible P wave. But, and remember we talked about A flutter, how it usually comes in like a pattern, but there's always a variable, right? It doesn't always come that way. Sometimes it comes that way. Most of the time it comes in a pattern like 3-to-1, 2-to-1, 4-to-1. But with this, it's saying that it has waves that are changing morphology, which means it's not a pattern at all. It has sawtooth waves, but it doesn't have a common pattern like a 3-to-1, 2-to-1. But it is still characteristic. So if you would have said this really looks like AFib, I would have said, you know what? I agree. I think it looks like AFib too. If you're going to go even deeper into it, and we were for that purpose, I would never put this on my exam and expect you to differentiate this between AFib and A flutter, especially not with, we're not like specializing in this, right? But it is important to know that when I don't have a P wave and when I have an irregular rhythm, it is an atrial either fibrillation or A flutter. Those are the only two options. Okay. 34.
Is that a Winky block?
I don't know. Is it? Is your PR interval getting progressively longer or is it constant?
It seemed to me to get longer and it dropped the QRS.
Are you counting the boxes? Nobody else wants to chime in here? Help a girl out?
I'm having
It looks like
seeing
it's
the
saying
boxes.
Say that again.
the intervals
I
to me
just
look
said I'm
like they were
having
the
trouble.
same. But I thought it was the same thing at first too.
Sinus arrhythmia, basic sinus rhythm with blocked PAC if more advanced. What? This has a constant PR. Okay. If I were to use this for my exam, my PR interval is 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. And then I have a dropped QRS. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. I would use this rhythm as a characteristic second degree Mobitz 2. It has a constant PR with a dropped QRS. Mm-hmm. 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 Let me find another one just like it. Come on. Well, we're only going to have that many blocks on here, guys. Haven't even seen a third degree yet. Okay. Okay, so 112. One, two, three, four. 1, 2, 3, 4. 1, 2, 3, 4. And then we have a dropped QRS. And then. So apparently this website is calling a Mobitz type 2 a sinus arrhythmia because it has dropped QRS and a constant PR interval. Because now that's the second one that it's calling that. And that's very annoying. Okay, so this says the difference between sinus arrhythmia and a second degree type 2. A sinus arrhythmia is a benign rhythm where the heart rate varies naturally with breathing. It's faster on inhalation and slower on exhalation. And then type 2 obviously is that the impulses from the atria are suddenly and intermittently blocked from reaching the ventricles, typically without warning or changes in the PR interval. So it looks like a dropped QRS to me. So I need you to show me what you think is a second degree, Mr. Website. Here we go. What's this one? 1, 2, 3. Second degree Mobitz type 1. That's a Linky Bach. Oh, here's your third degree right here. 131. So see how my PR interval is constantly changing? So remember, well, I told Latasha this, I told my lab group this, so I'll tell everybody. When you're looking at a third degree block and you're thinking, okay, I don't know what this is this a third degree? You need to ask yourself 2 questions. Number 1, is your PR interval constant? Okay, the answer to that question should be no. The next question is your rhythm, is your PR longer drop? Because a Winky Bach is always going to be longer drop. So this first PR, 1, 2, 3, 4, 5, 6, it's hard to count them. 7 boxes maybe. Then we have a dropped QRS. And then this next PR, 1, 2, 3, 4. Then we have another dropped QRS. Then we have this PR, which is huge. 1, 2, 3, 4, 5, 6. So we have dropped QRSs in between these random PR intervals. There is no relationship between the P's and the Q's. Can you see that? No? Yes? Maybe? It's all
Kinda.
the same. I need you guys to talk to me.
I didn't hear you, Jessica. What did you say?
Oh, I said, you can't hear me?
I don't think it was you. I think it was my iPad, my connection.
Oh,
It's
well, I
been
was
acting
saying with
wonky.
131, with number 131, this is a classic third degree block. Do you see that?
I see that.
Yes.
Okay.
Yes.
One 139.
Is that
A
A-flooded?
flutter?
Mm-hmm. A flutter with a 4-to-1 block. 141.
SVT.
SBT, baby.
You can put those on the fire now. So will 148 be A? Is that A bladder too? 148? Or would they say that's because I think A fib and A flutter, they be getting me a little confused, some of them.
Is it regular?
Yes. So
Right, it kind of looks regular.
is it A flutter?
But it's this is a poopy waveform. It is atrial flutter. So it must have some deviation with between the R waves, and I can't count them because if I touch it with my pencil, it screws it up. So, but in my brain with those sawtooth pattern, it's just so recognizable as a flutter. But then it kind of tricks you when you're just looking at it. It really does look regular. But if it is true a flutter, it can't be regular. $160.
That will be
VTAC.
yeah.
VTAC. And what is my question?
Do it have a pulse or no pulse?
Do I have a pulse? And what if I do have a pulse?
Cardioversion.
Cardioversion. What if I don't have a pulse?
CPR.
And
BFib, right?
defib, baby. 162.
It's a heart block.
Okay, what kind?
Second degree type 2.
No,
Is it a third?
it is
I was gonna say, I think that's
Oh,
a
that's what I
third.
said.
third-degree block. That is a third-degree block. Okay, this next one has to be a Mobitz type 2. It has to be. Ha! Thank God. We finally found one. Okay, so I think what I did was I mistook the T wave in that sinus arrhythmia as a P wave, and I thought it was a dropped QRS. And I think that's what happened. So this, if you look at this is the first beat, second beat. Here, this guy, can you guys see my cursor? Like the little hand?
Yes.
Yes.
Okay, so this guy is, this has to be a T wave. Because, so here's my P, here's my QRS, oop, here's my P, here's my QRS, here's my T. This is a P with a dropped QRS. See that? So the PR interval in this beat, the PR interval in this beat, and the PR interval in this beat are all the same. And this is where my dropped QRS is.
I think it's so hard to interpret because it's upside down. Like I know that you said like that's normal, but it's just irritating.
I know. It is annoying when it's upside down. But it happens all the time.
Would you put it
Ooh.
upside down on a test like that?
Probably not. But it is important for you to know that it can be inverted. And just because it's inverted doesn't mean it's not what it is. You know what I mean?
Yeah.
Like you still need to be able to recognize that it is what it is, but it's inverted, you know? It's 166.
Is it VTAC?
something else that we talked about that is not testable, but looks like a sound wave?
Is it the one that starts with a T? Day? I don't know how to say it.
Torsades de Pointe, which this is saying, torsades is a type of VTAC, but because it goes bigger, smaller, bigger, smaller, bigger, smaller, kind of like a sound wave, that's how I remember it, this is called torsades. Okay.
Miss Simmons, I have to log out, but I wanted to know before we left, is there anything we need to bring with us tomorrow to lab?
Make sure you dress appropriately. And maybe bring a stethoscope.
Okay. Thank you.
And you may want to bring maybe a book or something, your notes. Okay.
Okay. Thank you.
All right. Are we over this or we want to keep going? We got to wrap it up soon.
Yeah, but can you, so I'm almost 175. Can you do that one? Because I think like when I be doing the practice questions on like some website, it be giving me that it's not asystole.
It's not. This is fine
Okay.
VFib.
Okay.
That is not, no, that is wrong. This 176, this is ventricular fibrillation. This is VFib. This 175 with this waveform, and I will show you proof, by the way. This 175 with this chaotic little waveform, this is not asystole. This is fine ventricular fibrillation. If you had a patient in the ER coding right now, and this is what their waveform is, your doctor is going to defibrillate this patient. This where is it? I know there was another one.
Okay, because I was getting both answers when I was doing like practice questions.
But fine VFib is absolutely recognized as ventricular fibrillation. Where is the asystole? Where are you? Where are you? There it is, 82. See how there is movement, but it's a small wave. It's a little ripple in the ocean. That is asystole. Okay?
Noted.
Yes. 85, VTAC. 92, VTAC. See how they're different? Look at 92 and then look at 85. They look different. They are both VTAC. Any rhythms that we didn't look at that you want to see?
No, I think, like you said, it just
No.
takes seeing them and getting practice to just recognizing them.
100%.
What's the name of this
I'm not testing you
website?
on junctional rhythms. It's in that email. It's called
What did you say?
pacificmedicaltraining.com.
You said Pacific Medical?
pacificmedicaltraining.com. It's in that email with all the rest of the stuff.
I have a hard time finding stuff in there.
I hear you. 133. Make it bigger. It's a tough one.
Is it complete?
It is. That is a complete heart block, 3rd degree. I have no consistency or longer drop with my PR intervals. It's a mess. I got so many P waves, it's ridiculous.
I have a quick question. It has nothing to do with the EKGs, but it's for ATI. Will they let us know when they will reschedule it?
Yeah, they have to. They better let me know.
It won't be you. It will be like somebody else.
It'll probably be Bowling putting it on Brightspace or somehow. I don't know what it's going to look like, but there will be notification, and I will probably send it out in the group email too.
Thank you.
Mm-hmm. All right. What else can I do for you? It's been 2.5 hours.
I think you've done more than enough as far as me. I just need to go listen to the lectures again.
Can't say I never did anything for you. Just kidding. Any other questions about anything?
No, thank
Tomorrow,
you.
do we have to can we wear any scrubs or do it have to be our clinical scrubs since it's a lab?
It's a lab that is a clinical, it's part of your clinical hours, but it's a simulation. So yes, you have to be clinically appropriate. And yes, Stephanie, we are.
And what time are we to arrive?
I thought it was 8. I don't know. Let me see. Anybody have the schedule offhand? Let's see.
I'm going to go with
I put 8 to 4 in my calendar.
All right, let me confirm. 8 to 4.
And do you happen to know the address of the school where we're meeting?
I can give that to you very quickly.
Is it 2,300 Munson?
4,300
43.
Munson.
Okay.
Thank you. Ouch. Oh. All right. Tiffany, we're gonna have to jump off because this is recorded and we're gonna have to come back.
Okay.
Because I don't want it to be on the same recording, you know?
Well, thanks, Jess. Really appreciate it.
You're welcome.
Thank
Anybody
you.
else have any other questions?
Thank you.
No, thank you. Have a good
Thank
day.
you. Okay. Bye.
Bye. See you tomorrow.